The topic given by me by Firial is clinical applications of stroboscope and enhanced laryngeal imaging. So there are two things in here, stroboscope and enhanced laryngeal imaging, which in many literature, and if you ask many surgeons, they like to combine those two because it enhances the accuracy in the laryngeal examination, as well, especially when there are lesions on the vocal fold. So this is the content, just the outline of the lecture. I will talk a little bit on the principle of stroboscopy and enhanced imaging. And then how do we document, assess the findings of a stroboscopic examination, and what are the clinical applications? How can we use that in our clinical practice? Is it just a luxurious item, or is it a very pertinent instrument that is needed, necessary in our clinic? And I have some case demonstration to show. Video laryngoscopy is one of the basic protocol of voice assessment. If you have read this paper on basic protocol, which is published in by the European Laryngological Society, so this is a list of voice assessments that are recommended, because if you document all this, your paper will be more powerful, and more than that is you can compare the findings and the results of surgical intervention or any treatment for voice problems. So now we're going to focus on the video laryngostroboscopy, which help you to visualize the vibratory characteristics. Now, we're going to talk on the principle of laryngostroboscopy. First of all, before we see the vibration, we have to understand how it works. How does stroboscope, which is coupled with laryngoscopy, help us to visualize the vibration? Stroboscope is not something new. It has been used by other people. It is basically an instrument that makes a cyclically moving object appear slow motion or static. So in stroboscope, it has lamp that produce not a static light, but a repetitive flashes of light. And the timing of the light have to be matched, adjusted accordingly to the frequency of the moving object. Hence, you would be able to see the slow motion movement of the object. In 1878, Arthur has pioneered the use of stroboscope in laryngology. So it means that stroboscope is not only in laryngology, it has been used elsewhere in other departments. This video to depict how the stroboscope works, how the repetitive light enable us to see the slow motion moving object. This video is taken from YouTube, not from my own collection. So as you can see here, there is a plate that has black and white strips around it. When you make it move like a fan, you wouldn't be able to see the blades nicely. But once the stroboscope light is switched on and illuminated on the blades, and the frequency is matched to the frequency of the blades, now you can see the black blade moving in slow motion. So that's how the stroboscope works. So if this stroboscope light is transmitted to the phonetic vocal fold, which is vibrating, and the frequency of the stroboscope light match the frequency of the voice, delayed by a few seconds. So now, the stroboscopy is important for us to examine the health between the superficial mucosa, which is the cover, the epithelium over here, if you can follow the cursor of my mouse, and then the body over here, right? So people ask, why is it important for you to examine the vibration? Because by examining the vibration, it tells you the health between the epithelium and the body, and also the vocal ligament. So any insult in one of the layers of the vocal fold will affect the vibration. Now, let us see this mucosal wave, yeah, which is depicted on stroboscopic examination. So now, when you see that, the question is, how would you document it in your medical record? How can you share the findings with your colleagues, yeah, with other ENT surgeons or maybe laryngologists? So there must be ways how you assess the stroboscopic findings and document it. People have developed many tools on how to evaluate and document stroboscopic findings. This is important so that you can standardize the way you document and then standardize the way you communicate with each other. So there are many tools available. If people ask, is stroboscopic examination evaluation is objective? The answer is no. It is actually subjective. And we make it semi-objective by developing this tool to standardize the way we evaluate the vibration of the vocal fold. So on those many research tools or available to evaluate the stroboscopic findings, in our center, we use this one. It is called Stroboscopy Research Instrument, which is developed, validated, and published by Clark Rosen. So in this stroboscopic instrument, SRI, you look at this. First, when you see the vibration, you document whether the vibration, the mucosal waves are symmetrical or not. And number two, you see left and right, whether the amplitude is normal or not. Then I will talk later on what is amplitude. And then you look at whether the vibration is periodic or not. Then you look at whether there's any non-vibratory segment in this right or left vocal fold. And then you look at the duration of closure, which determine the phase closure, whether it is predominantly closed, half open, half closed, or predominantly open, and then the type of closure. So this is, I think, very useful and less, less laborious in the way you document the stroboscopic findings. So before I go further in talking about how we document the symmetry, the periodicity, the amplitude, and so on, everyone must remember how the mucosal waves are generated. So you have to maybe just recap your knowledge on myoelastic theory, the Bernoulli effect, where the subglottic pressure over here, which keep on increasing, will open the vocal fold from inferior to superior, like so. There's open and open and opening and is open. And then whenever there's passage of air through this narrow space, there will be drop of pressure and the vocal fold come together again. So this is closed phase, open phase, open, open, and close again. So during the close, open, and close again, we call it one glottal cycle. So if you remember, I said just now 250 Hertz, meaning 250 of this glottal cycle within 1 second. So it is impossible to be seen in the naked eye. So have a look at this slow motion of phonetic vocal fold. This is closed phase during phonation, and opening, and this is open phase, and then close again. So that is considered one glottal cycle. You will get these 10 frames. These 10 frames is actually chosen of many frames. So of these 10 frames, you look at in normal phonetic vocal fold, healthy vocal fold, it should be either predominantly closed or half open, half closed. I've seen that many in a normal vocal fold. So what is it? Why do you say it's predominantly closed? Because in 10 frames, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, only 4 frames shows opened face. So In that way, the patient can have a long maximum phonation time because the air from the subglottic pressure is released bit by bit in a short duration. So this is what we call a normal phase closure. And by using this montage and by looking at the open phase and closed phase, you can assess whether the mucosal wave is symmetrical or not. So what do we mean by symmetrical mucosal wave? If you can see during the open phase, the vocal fold right and left open at the same time. So that is symmetrical. It is like a mirror image. It opened at the same time with the same amplitude, with the same size. Periodicity means that it proximate at the same time. It has a good tempo, like tap, 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 tap. So it is periodic. But if the mucosal wave is like jittery, so it is non-periodic mucosal wave. Now we look at the amplitude. So the amplitude is you assess the vocal fold, how much the excursion of the vocal fold, the mucosal wave from midline to lateral. Okay, so let us go back to the video that I've shown just now. So this is the vocal fold in the midline, and look at this vocal fold, how from midline, okay, then close, from midline, there is an excursion slowly laterally. So that is amplitude. So this is how the amplitude of mucosal wave in normal vocal fold. In some cases where there is scar muscle tension dysphonia, where the false vocal fold is pushing the true vocal fold, and or in a patient with glottic insufficiency, you would see that the excursion or the amplitude of the vocal fold will be reduced. This is again duration of closure in a montage. You look at the phase closure, whether it is predominantly closed, predominantly open, or half open, half closed. So this is how you can standardize the way you assess, you document the findings of your laryngostroboscopy. Now we move on to the next subject. For you to be good at assessing the mucosal wave, you have to keep on thinking, systematically. What do you look at? And the moment you see it, or is it symmetrical? What is the amplitude? Is there any non-vibrating segment? What is the phase closure? So if you keep on doing that, you'll be better and better. And Ziad can share the experience that I told him from the start. You have to keep on doing this, so become a second nature to you. So what are the applications of the video laryngostroboscopy? Number one is for diagnosis of vocal pathologies. I want to say something about this. You don't need laryngostroboscopy to diagnose a big lesion, like you have a big polyp. So without stroboscopy, you can see the big polyp. But it is mainly to determine lesions that can't be detected with naked eyes. So that is have a higher function in terms of that. So I will show some cases which depict what I mean by it enable you to see lesions that can't be detected with naked eye. And it also helps you to differentiate functional and subtle structural changes. It helps you probably to determine whether this is vocal fold paresis or actually normal. And especially in early stage of laryngeal cancer, you want to probably can differentiate whether this is pre-malignant or malignant lesion. And it also can help you with the treatment decision, how soon you have to go in, also to track treatment progress. So this is basically the clinical application of video laryngostroboscopy. Probably if I show some cases, we can understand more what I meant by the clinical applications. So now, have a look at this. This patient complained of hoarseness for many months, more than 6 months. Okay, and the patient is referred to our center. So I want you to have a look at me and tell me, you don't have to tell me, and think whether there is any lesion on the vocal fold. Something very important that I want to stress on here, when we examine the larynx, we have to do personal examination, which means the tip of your camera have to go as near as possible to the vocal fold. So right vocal fold, left vocal fold, can you see any lesion? So that now I turn on, in this patient was referred to me because the doctor said couldn't see any lesion on the vocal fold. Now
Prof. Marina, I think you've gone frozen again. Maybe because of the video. Can try once more.
Firial, how long was I was frozen?
Few seconds.
Few seconds.
Few
Can
seconds.
can you see my slide, or I have to reshare?
You need to reshare it, but it was only for 3 seconds only.
Okay, I reshare. I'm so sorry about this.
No, it's okay. It happens.
Yeah. So here you can see that. You can see that there is lesion on the right vocal fold. There's reduced amplitude. The mucosal wave is asymmetry. And the middle part, you can see that there is no pliable mucosal wave. Yeah? There's no curtain effects of the generation or propagation of mucosal wave from the midline laterally. So this patient, I put him under general anesthesia, biopsy the lesion, and it turned out to be tuberculosis. Now, another example, this patient is a teacher, and she complained of hoarseness and difficulty to project her voice, and she frequently have voice breaks during teaching.
Semasa saya masih kecil, saya tinggal di kampung bersama nenek. Ayah dan emak tinggal di bandar, abang dan adik saya tinggal di bandar bersama ayah dan emak.
So for me, she has roughness of grade 2. There's strain component as well in her voice. And on the left-hand side, I'm going to play a video which not using stroboscopy, white light, and it is not a video endoscope. So from this, we can see that the vocal folds are mobile. We don't see any lesion. And during phonation, probably there's small phonatory gap, and that's it. But we can't really tell what is the cause of the hoarseness. So this is where stroboscopy is really, really pertinent. Yeah, when someone complain of hoarseness, but you can't see any lesion, and you can't find out the diagnosis. And now this patient is re-examined using a laryngostroboscopy. This is the nose part. I'm going to
Think of Professor Marina again. Your screen is frozen.
We still can't tell, what's wrong with the vocal fold. And then we turn on the stroboscopic light. So I hope you can appreciate that. She has an hourglass closure, and it always during closed phase, only the midpoint meet up. It shows that there is already some edema over there. If she doesn't receive treatment, that may progress into vocal nodules. And you can see that on the right side, the amplitude is reduced compared to the left side. So now the diagnosis that we made here is vocal fold edema, chronic laryngitis with postnasal drip. And we treat the nose, reduce the secretion. We told the patient that the chronic postnasal drip causes chronic laryngitis, and you have been talking a lot, so that causes vocal fold edema, and that's the reason you have this issue. And this is the appearance of the larynx after treatment. Although she still have the mucoid discharge, but I want to show you the stroboscopic examination. Now she has complete closure, and there is no more hourglass type closure with the edema in the midpoint. So this is an example how stroboscopy help you to determine the diagnosis. Now another example, I have two videos. One is on this side, is my left, and there's on the right side. I'm going to play the first video first.
Tarik nafas, sebut I sepanjang yang boleh.
Okay, you look at the first video and second video, and then you tell yourself which one is muscle tension dysphonia and which one is functional voice disorder. So I've played the first video already. Continue.
Sekali lagi sebut I.
Okay, and then this is the second video.
Sebut bunyi I. Okey. Nafas. Tarik nafas. Macam tu lah. Dah air down.
Stroboscopic examination. You can see here in this video, there is a lot of muscle tension dysphonia, but there is no vibration at all. Compared to the first video, there is muscle tension dysphonia, but there is still vibration of the true vocal fold and the false vocal fold vibrating as well, because it's kind of very close to each other, muscle tension dysphonia. So based on this laryngostroboscopy examination, based on my observation, the stroboscopy can help to tell you whether this is functional or muscle tension dysphonia. For me, the first video is muscle tension dysphonia. The second video is functional voice disorder, which the patient forget how to produce vibration to the vocal fold. The larynx is locked in abnormal position until it becomes stiff. It's not because the vocal fold have lesion, it's just that the vibration wouldn't open because the larynx in locked position. So that's just another clinical application of laryngostroboscopy. Now, the next one, I'm going to dive into the enhanced laryngeal imaging. But before that, a little bit on vocal fold lesion. So when we treat patients come with voice disorder, we frequently encounter vocal fold lesion that the diagnosis may range from benign, pre-malignant or cancerous lesion. And often we have a diagnostic dilemma, how to differentiate this. And we have to dilemma whether should I put the patient under general anesthesia, biopsy it, and most of the time, when we are doubtful, the results will come back as benign, and the patient would have scar, permanent scar, and the voice become hoarse lifetime. On the other hand, if we don't do biopsy, the lesion may progress, become pre-malignant and malignant lesion, which may happen in about 6 to 7% of cases. So you need a very good tool to help you in decision making. Which cases that you can wait, which cases that you have to go bring the patient to the OR as soon as possible for biopsy, regardless the risk of vocal fold scar. So there is a paper published by this group of authors, Chen et al., a morphological classification of vocal fold leukoplakia, in which just by looking at the nature of the leukoplakia, will tell you the urgency of biopsy and getting diagnosis for the patient. So there is a type 1, which the leukoplakia is singular, flat and smooth. The other one is elevated and irregular, and this one is wrinkled and corrugated. The number 3 is very high risk and very urgent for you to do biopsy, which likely to be malignant. And the second one, it could be either one, but the risk is definitely higher than type 1. So I have my own collection of cases which shows that the single and smooth one turns out resolve spontaneously with treatment, vocal hygiene, treatment for laryngopharyngeal reflux, and so on. The second one look elevated but smooth, and this patient has been like on my follow-up for 4 years already, and the patient still refused biopsy. However, the third one is categorized under type 3 with corrugated, irregular. This kind of case, you should not wait, and you have to persuade the patient to give consent for EUA and biopsy. I have a case, a patient who referred to me because the patient is a chronic smoker but unsatisfied with the diagnosis of laryngopharyngeal reflux given by other doctor because of this finding. So this is examined. This examination was done elsewhere using not a video endoscope. This patient was diagnosed as LPR and was given treatment. And the patient referred to me, repeat the examination using a video endoscope, which is camera at the tip that equipped with stroboscopy and enhanced laryngeal imaging. So with video endoscope only, white light video endoscope, you can clearly, there's actually lesions bilaterally. Mention dysphonia. And this is on enhanced laryngeal imaging, which I'm going to talk more about. Remember the SRI, there is asymmetrical mucosal wave, reduced amplitude bilaterally, but you can't really examine the whole vocal fold for any non-vibratory segment because there is severe muscle tension dysphonia. So a study looking at the differences in diagnostic value between just using a fiber optic, which the camera is at the beginning of the scope, and with video endoscope, which the camera is at the tip of the scope. So on this study, it shows that the video endoscope have higher sensitivity and specificity in detection of mucosal lesion and malignant lesion, in which from this study, it is extrapolated that if you don't use a video endoscope, you use a fiberscope instead, you have a chance of 11% missing out malignancies, laryngeal malignancies in outpatient setting. So we do not want that to happen. And with video endoscope equipped with stroboscopy and enhanced laryngeal imaging, it will increase the accuracy of evaluation and detection of early vocal fold malignancy, according to this paper. So what is enhanced laryngeal imaging? We talked about stroboscopy. Now we deep dive into enhanced laryngeal imaging, which is now available in different names. Enhanced laryngeal imaging is advances in endoscopic imaging technologies where it provides high resolution and digital chromoendoscopy. The main aim is to detect early lesion, which probably cannot be seen with white light, and more importantly is to examine the vascular pattern of lesion on the vocal fold. We're not talking about just vascular pattern on the vocal fold, but more importantly, when there is mass, when there's lesion on the vocal fold, you want to examine the vascular pattern of in the lesion that may help you to determine whether this is benign, a pre-malignant, or a malignant lesion. So in enhanced laryngeal imaging, I am going to mention these two systems which is widely used. Number one is NBI. Another one is iScan. So NBI is a pre-processed system in which before the image is taken, the system already alter the bandwidth of the light, the bandwidth of the white light. So when they alter the bandwidth of the light, it makes the vessel can absorb the light. It makes the superficial and subepithelial blood vessel appear darker or in a blue or green light, like so. Yeah, so you can see the vessels over there, which absorb the light that has been altered. Another system, iScan, is a post-process system, which image is taken and then the contrast is altered with the same aim to enhance the vascular pattern. It is not green light, it is more natural, which is red, and you can see the vascular pattern when the contrast is adjusted. The enhanced laryngeal imaging and stroboscopy is available in real time in this system, which you can do both at the same time. Stroboscopy together with iScan, which I'm going to show in some videos afterwards. Now, I want to just talk a little bit on vascular pattern. This is a proposal on a guideline on how we examine the vascular changes by European Laryngological Society, which is published in 2015. So in this paper, the vascular pattern, the vessel on a lesion is divided into type 1, type 2, type 3, and type 4. The type 1 is basically a benign lesion. It indicates a benign lesion, whereas you can see a longitudinal vessel on the mass from the surface, which look tortuous and ectatic. Whereas type 2, type 3, and 4 are perpendicular vessel, which the vessel come from the base and go to the surface of the lesion. That's why it is called perpendicular surface. And based on the pattern of the vascular pattern, it may tell you whether it is pre-malignant or malignant. This is a cut section, a diagram published in the paper, show a cut section of the vocal fold. Here is the muscle. That is the vessel which is parallel to the muscle of the vocal fold. And here is the lesion. And that is the perpendicular vessel, which is produced by angiogenesis. We call this intraepithelial papillary capillary loops, or IPCL. Secondary to epithelial cancerogenetic stimulus. So it is perpendicular to the surface of the vocal fold and feeding the lesion on the vocal fold. In the precancerous lesion, normally it shows symmetrical arranged dot-like loops with narrow angle turning points. I want to show it here. This is a patient with leukoplakia. You can see there's symmetrical arranged dot-like loops. There's two dots, two dots, two dots here because of this. There's narrow angle and you can see from the surface one dot and another dot. So this turned out to be high-grade dysplasia. Whereas in cancerous lesion, you can see over here, the vascular loops become spiral and worm-like. As shown in this mass of the vocal fold, you can see the worm-like lesion on the surface. This is a perpendicular vessel from the base feeding the tumor, and it shows a spiral-like lesion. A spiral-like vascular pattern. Now, maybe we can skip this. Okay. What I want to tell here is, in the treatment of early glottic carcinoma, if you are thinking of offering laser resection, a diagnostic workup preoperatively is important, and especially enhanced laryngeal imaging. It will help you in surgical mapping, and stroboscopy will help you to tell you how deep is the lesion, whether it has involved the vocal ligament or not. So I'm going to show you some case demonstration. This is case number 1, and an 84-year-old male with a chronic hoarseness and then occasional alcohol consumer. The patient stopped smoking more than 20 years ago. And this is how the vocal fold looks like. They're mobile. I'm not worried about the right side, but look at the left side. It is type 3 leukoplakia. And when you turn on the eye scan, this is on eye scan 3, you can see the perpendicular vessel in between the leukoplakia, which look like a type 4 spiral-like vascular pattern. And this is stroboscopy, which is coupled with enhanced laryngeal imaging eye scan in real time. And you can see a lot better how the vibration reduced. There's some parts there's no vibration at all, and the amplitude is reduced. Please look at the right amplitude and the left amplitude. It is clearly showing that the left vocal fold amplitude of the mucosal wave is reduced, and the side where there is type 4 vascular pattern, there's no vibration at all. In this case, you have to persuade the patient, tell, look, I think this is malignant tumor, you need a biopsy and you need treatment as soon as possible. Patient agreed for examination under general anesthesia, and biopsy is taken, and the patient agreed for us to take as much as possible, therapeutic as well, but we do this the right side on the second stage because we don't know the diagnosis yet, to prevent anterior glottic wag. This is how it looks like under general anesthesia. So that patient, the biopsy confirmed to be squamous cell carcinoma. Another case, a patient, a 40-year-old male who is a chronic smoker, and he uses his voice a lot, a contractor, yell a lot at the site where he works. And this is video of the larynx on eye scan 1, enhanced laryngeal imaging. Let us see, this patient has masses on the left vocal fold, as well as some leukoplakia on the right vocal fold. One look, we may think that this patient has glottic carcinoma. Okay, but look at the smooth lesion on the mid portion of the left vocal fold, and look at the vascular pattern. It looks like type 1 rather than rather than a perpendicular spiral worm-like vessel. And look at this paper, which is published by European Laryngological Society, showing the type 1 vessel. And this patient had, this is a type 1 vessel. This patient had undergone surgery under general anesthesia, and it was treated like a polyp. Cold instrument was used, like so. And this is the view of the vocal fold 5 months after the surgery. This is on eye scan 2, eye scan 3, and this is the video stroboscopy. Okay, the patient has voice improvement, although we can see there's reduced amplitude on the side where we did surgery. Probably there's some scarring had occurred. Case number 3, the last one, it is useful for surgical margin, surgical mapping. As I said, if you want to get a good outcome, when you want to perform CO2 laser resection of early glottic carcinoma, it is useful for you to map the side of this patient. Look at, there's no vibration on the left vocal fold compared to right vocal fold. It shows that the tumor has involved deeper. It has involved the vocal ligament. This is done together with eye scan 3. And when you do personal examination, give a proper local anesthesia. You go nearer, change to enhanced laryngeal imaging. It looks like the tumor is big. It has involved, is a bulky tumor, and not just the superficial part of the vocal fold. It has involved the infracaudal as well. So you have to do this for you to plan the resection of tumor. Then under general anesthesia, the anterior commissure was not involved. So instead of doing type 6 chordectomy, type 5A was performed. The patient concerned with the voice, and injection laryngoplasty using fat was done. It bulked up, and this is 4 months after type 5A chordectomy. This is eye scan together with stroboscopy. If you remember, with the tumor, there is no vibration at all on the left side. Now there is, probably you can imagine some vibration, but definitely the voice is better compared to before operation. So in conclusion, video laryngostroboscopy is an important tool in assessing vocal folds in patients with voice disorder. And particularly if the patient there are no lesions can be seen, and yet the patient have hoarseness. And by right, if you want to run a voice clinic, laryngostroboscopy is a must. Laryngoscope combined with stroboscopy will allow assessment of the vibratory characteristics of the vocal fold, and laryngeal evaluation using high definition video endoscope. And the camera at the tip is mandatory. If you don't have stroboscopy, you don't have enhanced laryngeal imaging, at least you must have a video endoscope rather than the fiberscope. If you combine video stroboscopy and enhanced imaging, it will increase the accuracy of the evaluation and detection of early malignant lesion, and will help you in diagnostic workup, pre and intraoperative endoscopy to map the tumor for you to get good outcomes. With that, that's all from me. Thank you so much. I open if there are any questions.